And once again, really happy to be here with you, even though I will have to leave shortly. Sadly enough, it's always, if you're opening these sessions and cannot enjoy all the excitement, that's quite frustrating. But this is a really interesting information session on the project Test and Treat, and a very special welcome to our partners from the Nigeria and Zambia Ministries of Health, as well as the Clinton Health Access Initiative, CHAI, some old friends and colleagues, the country offices and headquarters team. And as I said, this is a really interesting session. And if we frame this appropriately, we have to go back to end of 21, so 3 years ago now, still in the middle of the COVID-19 pandemic, when the Omicron variant first emerged in Southern Africa. And we recall well, and personally, I recall really well the panic when we realized that it was so much more transmissible. And you also will remember the lockdowns and travel bans that immediately followed. It was immense relief when we realized that Omicron infections were less severe in most cases, but that's something we only learned over time. We didn't know at the moment. At that time, the idea of a highly transmissible variant was so frightening. We thought that morbidity and mortality might increase, filling hospitals around the world with people in need of care and treatment. And it's exactly in that context where we saw this new variant emerging and not really knowing how bad it would be, that the project Test and Treat started. In March of 22, WHO announced a new recommendation for the first oral antiviral, molnupiravir, which was followed shortly by the recommendation for Paxlovid. That spring, we were still 12 months from the WHO declaring the COVID PHP, I always struggle with the name. But of course, how could we know that we were sort of moving towards the end of the pandemic? There was still huge concern about the potential for new variants to wreak havoc and to ensure that we had new and effective countermeasures in oral antivirals to deploy if needed. And that's the origin of Project Test and Treat. And the Global Fund, working with other ACT-A treatment pillar partners, decided to commit to a no-regret approach by committing funds to potential volume guarantees of Paxlovid, while at the same time helping countries to introduce these new products, address regulatory gaps, adapt guidelines, and develop effective integrated service delivery models. We're, of course, deeply fortunate that that nightmare scenario did not materialize, but the project intended to ensure that countries would be ready to respond should we have had a more pandemic evolution, and that's a really important lesson learned. And as you will see in the presentations from our country partners, these integrated test and treat service delivery models, similar to the models we've supported for HIV, TB, and malaria, were effective, both the upstream aspects as well as, most critically, in developing and rolling out the innovative service delivery models needed to deliver these new tools to people and communities in need. As you're listening to these sessions, I particularly like to call your attention to the implications for health systems resilience and preparedness for future threats. As our Ministry of Health partners will emphasize, the learnings from COVID Test and Treat must be applied and can be applied to our current and future approaches to the way we think about the integration of health services, as well as the health and community systems which they depend on. Thanks again for joining, and to our partners for their work and taking the time to share with us today. And I wish you all a productive session. I will listen in a little bit until I have to move. Over to you, Marcella.
Thanks, Marika. And without further ado, Sean, I think you're next.
Thanks, Marcella. And thank you, Marika. We appreciate you joining. Hi, everyone. My name is Sean Regan. I'm the Senior Director of our COVID treatment work and our pandemic preparedness and response work here at CHAI. I'm going to be giving a quick intro to our organization for those that are not familiar, then go into just a single background slide on the project, and tee up Jess from CHAI to talk a little bit about our operational research across several countries, and then really turn it over to the Ministry of Health in Zambia and Nigeria to present on their experience with the work and lessons learned and recommendations for enhanced preparedness and response efforts moving forward. But thank you again to the Global Fund for hosting this and pulling this together. We're really excited to present on this work. So just starting off, as you can see here on the slide, CHI is a global health organization that really works closely at the intersection of governments, business, and other global health actors to promote more equitable access to healthcare and ultimately save lives. Our mission is really oriented around working hand in hand with our Ministry of Health partners. So that is really our goal and our key to our approach as CHI. We work directly with over 35 countries across Africa, Asia, and Latin America. And as you can see here at the bottom of the screen, really across sort of 20 core programs. But there's a lot of work and a lot of components to each one of these across infectious diseases, women's and children's health, health systems, very cross-cutting work, NCDs, and then also we have very specific experts teams that work on global markets and diagnostics, for example. Next slide, please. Thanks, Marcel. So as Marika mentioned, throughout the pandemic, we didn't have access to great oral antivirals, or sorry, any antivirals really in the settings that we're talking about until late 2021, when molnupiravir and nirmatrelvir were provided with FDA EUA. There were monoclonal antibodies and remdesivir that came to market, but there were various challenges to actually rolling those out, and also ultimately efficacy issues with the monoclonal antibodies that were developed. But once we actually had true effective oral antivirals, taking a public health approach at scale and utilizing a really effective model of care in these settings was really feasible. At the time, again, as Marika alluded to, we were anticipating, after Delta and Omicron, that there would be future waves of that size and magnitude, hoping that there wouldn't be, of course, but we all knew that we needed to be prepared. And to do so, we wanted to complement the vaccine rollout effort to ensure that antivirals were available to that were, sort of at elevated risk of hospitalization and ultimately death from COVID infection. And as Herb Harwell on our CHI team often says, you don't stop wearing seatbelts just because you have airbags, right? So that really speaks to the complementary nature of having vaccines and effective oral antivirals to those that are at really high risk. So the approach that we decided to take was to start working with several quick-moving countries, being Nigeria, South Africa, and Zambia. And as you can see on the slide here, there's a quite high number of high-risk individuals in each one of those countries, according to the protocols and how we understood, who was at elevated risk for poor outcomes. We as CHI ultimately ended up supporting over 14 countries across Latin America, Southeast Asia, and Sub-Saharan Africa with test and treat rollout. And this was really complementary work to what we were doing here with this TNT project. Before we move forward, I'm going to note that the South Africa work didn't actually end up moving forward. There was a decision by the National Essential Medicines List Committee, also known as NAMLAC, in 2023 that not to move forward with nirmatrelvir rollout in the public sector for the South Africa context. So we're really going to focus in today on Nigeria and Zambia. And as part of our broader work as CHI, together with the Quick Start Consortium that we started with the COVID Collaborative and together with Duke University, we conducted operational research in 5 countries. Again, very complementary to the work that we were doing in Nigeria and Zambia, and those are 2 of our OR countries. And so as we move forward with this presentation, we're going to dive into a bit of a readout from our operational research work across these 5 countries to sort of provide a high-level view of that work. And then we're going to turn it over to our Zambia and Nigeria colleagues to really talk about their program experience, and how priorities really evolved as COVID evolved, as we had the end of the fake, as testing really scaled down in the years that went on for our program. Demand for COVID services really went down, multiple headwinds coming again and again towards these programs that really sort of led us more about surge preparedness and lessons learned and recommendations for enhancing preparedness and response efforts moving forward, whether it's for COVID or other emergencies that our partners are facing. So I will pause there. Jess, I'm going to turn it over to you. And Marcella, if we could move on to the next slide, that would be great.
Great. Good afternoon or good morning, everyone. My name is Jessica Joseph. I am a research fellow on our analytics and implementation research team, and so was helping coordinate all of this research that we did in the 5 quick start countries. You can go to the next slide. And so we just wanted to give you an overview of the research that we conducted and some of our preliminary results. This is unpublished data, so please don't screenshot or share beyond, although results will be forthcoming very, very soon. But as Sean mentioned, as part of the Quick Start Consortium, we wanted to be able to describe a little bit more the cascade of care and really the feasibility of implementing a test and treat program. And so what we did was we put a research protocol into place that was going to measure the number of high-risk COVID-19 positive patients. We looked at turnaround time to treatment initiations. Today, I'm just going to really describe the cascade of care and the number who were screened from positive to eligible to being prescribed and initiated on oral antivirals, and a little bit on the turnaround times. And so it was a retrospective study, meaning that all of our work was programmatic that we did. And so we just went in afterwards and extracted data from health registers that the healthcare workers had captured at the facility level. And so you can see on the right that this was conducted in Ghana, Malawi, Nigeria, Rwanda, and Zambia. There were anywhere from 4 to 20 research sites that we used. Although I should mention in Rwanda, they really used the hub and spoke model. So their 15 sites were district hospitals that really included all of the surrounding health facilities in the catchment area. And then the research started as soon as the country had the drug in place and it was out in facilities. And so that happened first in Zambia back in the end of December of 2022. And as each country started implementing, we started capturing their data. And then we collected data through June of 2024 of this year. You can go on to the next slide. So this slide really shows our overall results. We screened just over 2,000 participant countries. Among those, we did try to capture eligibility. We had some issues with missing data, especially early on in our program when we were really trying to just roll out quickly as possible. And again, because this was research that was just happening in a real world setting, some of that data wasn't always captured. But among what we did, we found it was about half that were eligible, and almost all people who were eligible were eventually prescribed nirmatrelvir or ritonavir. So we had a total of 1,319 people prescribed. And then as part of our research, we wanted to conduct both a 10-day and 30-day follow-up. So we were able to follow up 74% of the people who were prescribed. And at that follow-up, we asked them, did you actually, initiate on treatment, and did you complete your full 5-day course? We also asked them some other questions, whether they still had symptoms or side effects. But you can see we had extremely high rates of initiations. 99% confirmed to have initiated on the drug, and 98% confirmed to have completed the full 5-day course. Most of the reasons why people didn't initiate, we had a few facilities that were stocked out and they couldn't get the drug to them in time. And then the reasons for not completing 1 or 2, I think it was from side effects. Next slide, please. So just to give you a little bit more information on this, because we did capture data at a individual level and not an aggregate, we were able to dive into the characteristics of who we were looking at a little bit more. So on the left-hand side of this slide, you'll see high risk factors. I should say two things to note on this. Number one is that this is all self-reported. We didn't, test people to see if they had hypertension or diabetes, et cetera. This was just all what they reported back to the healthcare worker at the time that they were screened. And then also, we decided to decrease the age limit for eligibility. At the time, WHO was recommending 60 years. We decreased down to 50, really as a hope of trying to capture some of those other maybe unknown or unreported high-risk factors. And so, no surprising then, age over 50 was the most common high-risk factor, followed by hypertension, and also in our settings, people living with HIV. We were also targeting testing in HIV clinics, so that was not a surprise that we had more people coming in for there. And I should say overall, it was just under half of the people that were screened had at least one high-risk factor. They could also have more than one. And then on the right-hand side of the slide, you'll see some of the side effects that we captured from our follow-up data. So it was about 55% who reported at least one side effect. Most of this was reported in Zambia. We're not sure why there was such wide variation, but in Rwanda, you can see in the box, only 4% reported any side effects. And the most common side effect by far was the metallic taste. Not a surprise to anyone, but did reconfirm that in these same settings, we're seeing the same things. And then the last thing we really wanted to do was, even though this was not an efficacy trial, we knew the drug had already been proven. There was many other papers put out there that it was effective. We did want to do our due diligence and monitor safety. And so any events were reported. And at the end of our study, we only had two. I believe one was from Ghana, the other from Malawi, but neither was attributed to the actual drug. So proving, again, that Paxlovid was very, very safe and acceptable in this context. So that's just a smattering. As we mentioned at the beginning of the call, we have a lot more dissemination coming out. We have a manuscript that we will be publishing in the next few months, and so just wanted to give you guys a quick look into what else we did. And great, thank you.
Thanks, Jessica. We have our colleagues from Zambia next. Sean, I'm not sure if you want to say something before our colleagues go.
No,
okay.
We are all set to move forward.
Afternoon, everyone. Thank you so much for the opportunity to speak with you. Dr. Newman Bewe from the Zambia National Public Health Institute. I am an infectious diseases physician, and I was the focal point person for the Test and Treat program in Zambia. So we did launch the program in December of 2022, and were able to deploy the services, the Test and Treat services across the we managed to have sites in 8 of the 10 provinces, and that was in 36 sites, primarily government hospitals, mostly the second level and tertiary hospitals, but we also had some of the private facilities were also on board to have Test and Treat offered in these services. And in terms of the models of care, the patients were screened. In terms of models of care, patients were screened from different testing points throughout the facility, particularly the emergency room. Patients would present to outpatient clinics, the TB clinics, and especially the HIV clinics. And so testing was done on site, symptomatic testing, and then positive patients were then assessed and determined if they need additional care. And then we did have post-COVID clinics that would do the follow-up of the patients. And so the exact model was different depending on the level and type of facility. But overall, we were able to have most of the patients seen in all of these facilities. And I think to especially mention the bidirectional screening of TB and COVID that was post-COVID that was being done. And I think that was one of our successes from the Test and Treat program. Next slide. So overall, we started, like I'd mentioned, the program started in December of 2022. It actually started at one of our peaks. And so I think it was quite fortunate at the time that the medication was available in country. And over the last 2.5 or so years, we've had 3 slight peaks where we've been able to see an uptick in patients receiving the medication. Particularly what we've noticed is our trends are towards December December, January, and again mid-year around June, July, which is sort of our winter period. And overall, the number of individuals who were tested positive during this period, we had 3,505, and of these, 1,504 were actually prescribed medication. I think the next slide, as we discussed the eligibility. So coming now to the eligibility, for those that did meet the criteria, 92% of these had actually been prescribed treatment as it was available, and then 95% of these were confirmed. This is particularly from the operational research sites. You recall I mentioned we had 36 sites that were activated across the country that were providing test and treat, and then of these we had 12 that were specifically selected just to provide the evidence that we needed. And so when you look at the patients that were eligible at the OR sites, of the 899, we had 312 that were actually eligible, and I think 363 are the ones that we didn't have the missing data about the eligibility. But as we came down the cascade, we were able to demonstrate that majority of the patients who were screened and positive, 92% of these actually did get prescribed the treatment, although we did have issues with patients completing the 10 days follow-up. Next slide. So this will be my last slide, just looking at some of the characteristics of the patients in terms of risk factors. I think Jess did talk about the age that was reduced. That had actually been one of the contentious issues when we initially, the WHO recommendations of 65, but you know that Zambia does have quite a young population. And so you can see majority of the patients that did meet eligibility age was one of the factors. Of course, other factors such as hypertension, TB, HIV, seeing as that was where we sought the patients, as well as obesity and diabetes, etc. And I think another thing that we did quite well was in terms of when to start the treatment. 87% of the patients actually received it within the first to the fifth. So I think the team did quite well with that, as 94% of the patients were captured within that period. I believe that was my last slide. I will hand over now to Prof. Malinga.
Thank you, Dr. Mbewe. So what we have done is just
Muito
from the beginning
obrigado.
when we are initiating.
Na verdade, vamos então prosseguir.
When we are initiating the test and treat, we had in mind issues of sustainability.
Houve questões que foi necessário ter em linha de conta em termos de elegibilidade. Peço desculpa, estamos agora com problemas de som bastante precários. Iremos prosseguir assim que possível.
Services to do that. So we started using the PCR for testing for COVID, and we
olhando o teste para a COVID,
the first of antivirals in December of 2022, and what was impressive about it
e o que foi impressionante,
and at the time that we are receiving
o investimento feito foi
in March of 2023, already offering Paxlovid.
Portanto, a oradora prossegue com condições de som bastante precárias. Dr. Melinda, peço desculpa de interromper. Doutora, peço desculpa. Portanto, desenvolvemos um grupo de reflexão para a COVID e então foi implementada para abordar, ver o que se passava em relação. Portanto, são serviços de tratamento e testagem que são continuados a seguir a estes projetos de teste e tratamento, com esforço para integrar a COVID num estado de prontidão pandémico mais alargado, com os devidos planos. Assim, ao longo do tempo, foi considerado que era necessária uma gestão apropriada da COVID e outras doenças, e os produtos que eram necessários, considerando a eclosão da doença e outros seguimentos, e o restante seguimento. Pedimos desculpa, o som está com bastantes sobressaltos e precário. Dizendo que em relação aos vários planos que foram implementados à medida que se aborda a zona de risco. O próximo diapositivo. Portanto, principais lições e recomendações provenientes. O próximo diapositivo, pede a oradora.
Dr. Mulenga, we are in the next slide. It's just I think you cannot hear us. Your connection is
Parece que não nos conseguem ouvir. O próximo diapositivo são as lições principais e recomendações provenientes da testagem e tratamento da Covid-19. Consegue ouvir-me? Sim, conseguimos ouvi-la.
We were wondering if you can see the slide. It's key lessons and recommendations, because I think your connection is a bit patchy. Can you hear us?
I'm now able. Yes, I'm now able to hear. I'm able to hear you clearly, and I'm able to see the slide. So this is my last slide of the key lessons we have learned from the test and treat. The access to the antivirals in December of 2022 really enabled us to treat a number of individuals that were at high risk of progressing to severe disease. And also just the fact that we had global stakeholders and us setting up the local stakeholders made us really appreciate the role of having an integrative service delivery model as well. The early investments and country level initiatives were robust, and we think that with the leadership that we got also from CHAI as a key partner, that helped in the scale up, and not just of the treatment, but also the diagnostics as well, and rolling out to other diseases as I've highlighted. And the fact that we also looked at training various healthcare workers, the physicians, the nurses, the pharmacists, the laboratory staff, and also some of the key community members as well. It helped in rolling out easily the program as we did start. And we have moved on into integration of other services, integration with TB, integration with other respiratory pathogens, and also now using the multiplex open PCR platforms as an issue of surveillance. This, which was born from the test and treat program, is something which we do appreciate. So the integration of not just the clinical, also the laboratory services is a key lesson that we learned during this program. Thank you so much.
Thank you, Dr. Mulenga. I'm passing on to our colleagues in Nigeria. They can start the presentation.
Thank you so much. Thank God I can hear me. Can you hear me?
Yes.
Okay, great. Good afternoon, everyone. My name is Chukwemeka Agbocha, speaking from China, Nigeria. Program manager on the test and treat project. So just to run through this very quickly. The program was started late 2022, but we activated our sites in 2023. Across Nigeria, we worked across public and private facilities in 8 states. Initially, we started off with states were the Nasarawa, Rivers, FCT, and Ogun. And across the states, we were able to activate 42 facilities, both in private and public sector, rolling out test and treat model. But coming to 2024, we worked with the NCDC, which is National Center for Disease Control, through the enhanced surveillance testing to expand this work stream to additional states, and activating 27 facilities in the process. Just to mention, because call out the states spread across the North Central region, the Northwest, and also the Southwestern region. So totaling about 62 sites. Now, across these different facilities, or these facilities, we employ different models of care. At the facility level, patients who were coming in through the different entry points that manifested respiratory symptoms were screened and linked to care. For those who were found positive, picked up their medications, positive and eligible, got their medication from the pharmacy. Also, patients who were missed at the entry points on meeting the clinician, the provider testing and counseling approach, where patients who also showed symptoms were identified and tested and were eligible placed on Paxlovid. Furthermore, at the community level, also where we did a lot of work working through the enhanced surveillance model, it was more like integrating this COVID testing into the health outreaches and campaigns which was conducted. Similarly, patients who were positive and eligible were linked to care. Similar to what was shared with Zambia, the bidirectional testing strategy was also implemented, and also as part of case finding strategies. Just to highlight that all patients who were eligible were also followed up to ensure that we didn't have cases of adverse effects that needed or miss any documentation. Next slide. So looking at the testing which this slide provides, we could see we just had just 190,000 tests conducted between July last year and May this year across these facilities. But the interesting thing about this slide is you can see that in February 2024, we saw highest testing volumes happen. This was from the collaboration we had with the NCDC that drove a lot of testing across communities and facility levels. But as we go forward, we'll see that from April, we saw a decline in testing. And this was largely due to expiry of our current test kits in the country, and a shift by the country from the COVID response to the broader pandemic response. But in terms of linkage to care, the patients who were found eligible for 4% were all linked to care, and 46% of positive cases who were eligible for treatment, they were cancelled, and they were mainly children. So I'll just pass on to Dr. Dakum to just take us on the next two slides.
Thank you, Chukwuemeka. Good afternoon, teams. I will be presenting the findings or the results of the test and treat project in Nigeria. As you can see from the graphical representation of the bar charts, 86 patients were found positive. And out of these 86 patients, 66% were eligible for treatment, which represent 55 patients. And 54 patients were actually prescribed the treatment with Paxlovid. And they were followed up, 52 were followed up, and 52 completed the treatment, representing 96%, which were followed up and confirmed from initiation of treatment and completion of treatment. Please, next slide. As you can see, this is the categorization of the patients based on the symptoms, onset of symptoms, and their presentation in the facility. The Nigerian team did well. We had majority of the patients, which represent 72%, that is 53%, actually presented within the first 5 days of the onset of symptoms. And only about 11% came after 5 days of the onset of symptoms, which were 8 patients in number. And then those who came before the onset of symptoms were 13 in number. And among these, the 66 patients who presented in the 5 set of symptoms, you can see were the majority. The risk factor that was identified, major risk factor that was identified for each of the high risk participants are 1, those who had unvaccinated history for COVID-19 represented the highest, and they are 20 in number. And then the least were those with liver disease, which were 2 in number, and that proportion represent 3%, which is the least percent of those with the comorbidity. But the other risk factors that were identified were those who were with lung diseases, 5 in number, representing 8%. And then we had hypertension and HIV patients who were equal in number, representing 13 patients, and of course 21% of the proportion. But in all this, what the data demonstrated was that if a patient is not vaccinated for COVID-19 and is also of age that is above 50 years, it was found to be the most significant risk factor for those who participated in this test and treat program in Nigeria. So on this note, I will hand over to Dr. Okoli, who will take us in the other segments of the Nigerian presentation. Thank you, and over, please.
Thank you, Doctor. I think we continue with our colleagues in Nigeria.
Good afternoon, everyone. My name is Dr. Okoli, Dr. Ijomo Okoli, from the Federal Ministry of Health, and I'll be taking us through the next few slides. Now, looking through our key milestones from program inception till date, you can see that we successfully updated the COVID-19 clinical guidelines in the first quarter of 2023. We received the first batch of medicines, trained healthcare workers, and activated health facilities to commence test and treat services in the second quarter of 2023. Towards the end of the same year, we activated service delivery at the community level. Earlier in 2024, our focus was on ramping up testing at the community level, leveraging the NCDC enhanced surveillance testing. By mid-year, the country adopted a broader focus on pandemic preparedness, following the WHO announcement. In this last quarter, we have held data review meetings to enable them lessons learned. We have also conducted health facility visits to assess the status of pandemic readiness in line with the country's priority, and identified areas that need to be strengthened. In terms of sustainability plans, the COVID-19 response has largely been coordinated by the Nigeria Center for Disease Control, with the Department of Hospital Services of the Federal Ministry of Health involved in case management. While COVID-19 test kits are currently not readily available in the public sector, we work with the state teams to explore the feasibility of leveraging the PCR platforms in the states to conduct tests for symptomatic individuals. However, the cartridges to run these tests were not available, and to solve the stockout problem in short term, a donation of these test kits and treatments and medicines are expected early next year. Speaking on the broader efforts for surge preparedness, a National One Health Steering Committee was inaugurated last year to oversee surveillance of priority disease areas, operationalize the country's One Health strategic plan. The end-term review for the National Action Plan for Health Security was recently conducted, and some of the lessons learned from the test and treat program will be recommended and included in the new National Action Plan to strengthen community structures for event-based surveillance, which will be explained in the next slide. Next slide, please. Next slide, please. Okay. So, looking at the lessons, the key lessons learned from the implementation of the COVID-19 test and treat program, I'll be speaking about them in 3 major buckets. First of all, integrated disease surveillance. While implementing the program, we implemented the multiple entry point testing and the bidirectional testing, which enable testing for COVID-19 alongside other diseases such as malaria, HIV, and TB. And this highlighted the possibility of integrated surveillance models, thus the need for integrated testing protocols in the health sector. Secondly, empowering community structures for pandemic preparedness and response. When we commenced community-level screenings, we observed a significant increase in the overall number of positive cases when compared with the focus on health facilities alone. This was achieved through engagement and involvement of key community stakeholders, including local leaders, key opinion leaders, religious leaders, in demand generation and linkage to care strategies. For broader PPR efforts, clearly defining the roles of these community structures and inclusion of plans for routine capacity building of these stakeholders in guidelines on surveillance is necessary. And then on promoting investments in PPR capacities, the stockout of testing and treatment commodities highlights the need for domestic resource mobilization beyond donations. So the Nigerian government is currently focused on strengthening pandemic preparedness and response. And this we hope to do by strengthening the healthcare system through training of healthcare workers for timely management of emergencies, surveillance and case detection, and using the One Health approach for multi-sectoral collaboration, as well as tackling human and infrastructural deficits. Thank you.
Is that my cue, Marcella?
Yes, it's your turn, Dave. Thanks.
Great, thank you so much. Huge thanks to our colleagues from the Ministries of Health in Zambia and Nigeria, and our CHI colleagues as well, for the background, the larger strategic views, including the research elements, and then the more detailed and more granular perspectives from the countries, which has been really insightful. I want to first ask Marcella and Zayota, do we have any questions at this point that from the audience that we would want to provide for translation?
They're not at this point, not on the TNT project.
Okay, great. Well, I do have a few questions of my own, and I'll just jump right in then, if that's okay with folks. So I think one of the really striking aspects of the presentation of the session here is the choices that both Zambia and Nigeria made with respect to the integrated service delivery models. In the Zambia context, there's a deliberate focus on established routine HIV and TB service platforms. And in Nigeria, there was, a broader focus on a number of established primary healthcare service venues, but also inclusive of HIV clinic settings. And I'd be very interested to hear from both sets of colleagues from Zambia and Nigeria on the in evaluating the approaches that were taken. Have you essentially confirmed or validated the choices that you made in terms of thinking about future surge preparedness and the sort of comparative advantages that each choice provided you in your country context? Have you considered any adjustments to the approach that you've taken? Again, thinking about future scenarios where you're required to scale new products such as the oral antivirals for COVID-19. So maybe we could start with that question, and maybe I could ask colleagues from Zambia either Dr. Mulenga or Dr. Mabewa to provide any comments. Thank you.
Thank you, David. I guess maybe I can try go first, and I'm sure Prof will be able to add anything. But if I got the question right, it was on why we chose that particular model of working with the existing system, particularly TB, HIV. Is that correct?
Yes, thank you, Dr. Mbue. It's both Mbewe, sorry.
Sure.
It's both the route that you used initially, but also after the implementation for the past couple of years, has your evaluation of that approach confirmed that it was the right approach, or has it led you to consider other integrated service models that might have been more effective at reaching a broader segment of the population? Is that clear?
Yes, absolutely. That's clear. So I think part of the reason why we chose that existing model is that, remember, it had occurred during a slight peak in cases. So we needed a system that was already established and working. Before even test and treat was available, when we had the COVID-19 bigger surges, we were able to leverage on the existing HIV and TB networks. I think Prof had spoken about some of the testing platforms that were available. Human resources was already trained in management of acute COVID. So it was really just switching to this outpatient care model. So I think it was really just building on what already existed and was already working. And I think this integrated model, we've been able to build upon it. Like I'd mentioned, the bidirectional screening, so much so the model that we're hoping to use now as we set up our preparedness and response for Mpox cases. Again, because clinicians, nurses, the whole team's already trained. It's really just adding these additional, I guess, modules and components that people need to work on. And so I think having the experience with test and treat, and then also the aspect of the operational research, we've really been able to tweak what works and what doesn't. And the vision then is to have this work for more emergency preparedness and response and other outbreaks that we're likely to face. Over.
Thank you very much. Prof. Mulenga, did you want to add anything there?
Yes, as Dr. Mbewe has indicated, we realized that we needed to collect good data, relatively good data, with the test and treat as well. And we already knew that we are integrating the testing, especially for the respiratory pathogens, into the TB, the HIV spaces. And we thought that model did work well for us during the overall COVID pandemic in terms of the response. We think that it's a model which we can utilize for many emerging outbreaks as well. But also, we did not just use this platform, we strengthened the other systems as well, like the outpatient testing was encouraged, and the testing was being done from there, and just a referral system to those other established clinics is something which we strengthened. Again, having, like in one big facility, having different outlets was going to be challenging with our capacity. We have the capacity challenges with human resource, with data, and also managing of the logistics. We thought that using those established platforms which have worked well for us was key. Thank you.
Thank you, Prof. Mulenga. Before we go to the Nigeria colleagues, I'd like to ask just for 2 quick points of follow-up regarding the Zambia model. It was interesting that the percentage of the patients who are both eligible and initiated on treatment who identified as people living with HIV or with TB as risk factors were actually quite low from a percentage standpoint, which suggests that even though you took if you will, an approach that leveraged more vertical platforms, you were actually able to essentially broaden the access to many from the general population. So I'd be curious if you could also comment on that specific aspect. And also, you mentioned Mpox was one of my other questions, and I appreciate you mentioning that. It's striking that with Mpox, currently there are no RDTs, and there are no dedicated, i.e., specific therapeutics like we had with COVID at the time. Yet you are seeing, if you will, service delivery opportunities within the same platform. So I'd be curious. I'd be very, very interested if you could comment on that as well. And what is it about? Where is the opportunity that you note on a specific test and treat modality? Again, thinking about future surge preparedness. Thank you for that, and then we'll go to our Nigeria colleagues. Thank you.
Thanks so much. So in terms of the numbers for the TB and the HIV, indeed, I think we did manage to broaden it beyond just those particular clinics. I think early on when the medications were available, we did have like very public, very high level campaigns. I think the first of which had been launched by the Minister of Health. And so there was a general sensitization of the public on where they could access these therapeutics. But then also the fact that the ER services were, especially in the bigger hospitals, were 24 hours a day. So regardless, people would be directed on where they could access the medication. So I think that is a correct point to show that there was access beyond just the vertical TB and HIV services. But then coming specifically to Mpox, yes, indeed, there are no therapeutics at the moment. But I think an advantage of the test and treat system is that you did have patient follow-up. Nurses that were trained. We had the aspect of the M&D following up patients in the community. And hence our hope is that as the country so far, we've a single case. And so the first step is the active case search and really being able for patients to know where they're able to access such therapeutics if the therapeutics do become available. So I think those are some of the areas that we're hoping to leverage on. And then also the fact that we'd have trained nurses who would be able to help with the search and even symptomatic treatment of patients, and then also being the advantage of having proper data systems already in place that can then be leveraged on to build evidence. So I think those are some of the areas that we hoped to build upon. Over.
Wonderful, thank you. That's extremely clear. So let's turn, if we could, to our colleagues from Nigeria, MOH. Again, for a similar reflections or reactions to this question about the choice of integrated service delivery models for the COVID test and treat, and have you had any reflections on whether the approach that you took in this case is likely to be the right choice and the right model in the event of future epidemics and pandemics requiring similar scale up of test and treat? So over to our colleagues from Nigeria.
Thank you so much for your question. So I will start, and then Dr. Okoli will add up to any other context as it relates to Nigeria. So for Nigeria, we must first and foremost commend CHAI for the opportunity of introducing the test and treat model that we've used, even though piloted in only 4 states, and Nigeria has a complex health system. We have about 36 states plus the Federal Capital Territory and about 774 local governments. And our health system is structured that we have primary healthcare centers, secondary healthcare centers, and federal tertiary health institutions. But one clear pointer that would be derived from the test and treat model is the fact that it discourages verticalization or running parallel programs for disease prevention and control, especially when it relates to epidemic. It actually encourages the integration and routinization of care. So what the test and treat model has been able to do of pandemic preparedness for Nigeria is that, one, it has been able to train the healthcare workers in such a manner that they will now be more confident in handling future pandemics, and not just COVID-19 alone, but other emerging or epidemic-prone diseases. This has been demonstrated through the numerous trainings that have been done, and then the supportive supervision that has been conducted with these healthcare workers. And again, Nigeria, using the test and treat model, has been able to ensure that other disease prevention programs are also factored in to be part of the test and treat model or the pandemic response. And a bigger context of what Nigeria is trying to do is that the financing component of pandemic preparedness and response is Nigeria is trying to bridge that gap by bringing in an innovative context, which is just related to Nigeria, using the basic healthcare provision fund that Dr. Okoli stated in the lessons learned. So what is the context of the basic healthcare provision fund? The basic healthcare provision fund is a Nigerian strategy of ensuring that emergencies are tackled even at individual level without the individual paying, out of pocket at the point of service. So we have funds that is directly taken from the consolidated revenue of the country to support the health system and support health system strengthening. And this health system strengthening has 4 gateways. And these are components of pandemic preparedness and response. One of the components is the emergencies, so looking at medical emergencies. And this is to ensure that no Nigerian or no patient is allowed not to access emergency medical services within 48 hours of care, irrespective of his status, irrespective of whether he's insured or not. But after the emergency has been arrested, using the available funds that is available, other financing options can now come in. So that look at medical emergencies. So for public health emergencies or public health outbreaks, there is a public health security component of it, which a certain percentage of the fund goes directly to the National Public Health Institute to respond for pandemics. And because of that seed fund is specifically dedicated for manning public health emergency operation centers at the subnational level. And then we also have the ones that encourages universal health coverage. And that goes for the National Health Insurance Authority. And then the other gateways look at the primary healthcare centers. And that is where the bulk of the lesson learned from test and treat using the CHAI model, and is where the country has adopted. And of course, we are already in talks with CHAI towards developing a pandemic preparedness, a robust pandemic preparedness and response plan, an all-encompassing response plan for the country. And so I believe that the test and treat model is something that the country can adopt for the future. Thank you, and over.
Thank you, Dr. Chukwuemeka. That was very interesting and insightful in terms of reflections on the service delivery model, and also the sort of policy and operational decision-making that this experience has provoked in Nigeria, which sounds very ambitious. First, I want to check with Marcel and Ziota. Do we have any other questions that have come in through the chat that we should pose for translation?
Not at the moment, Dick. We don't.
Okay. So I'm just going to take the sort of moderator's prerogative to continue with another question. And Dr. Chukwuemeka, I'd like to pick up on one of your last points. This regards the issue of governance. Okay, and in both Zambia and Nigeria, the approach that you've taken to developing and scaling up COVID test and treat, and the way that you're thinking about future surge preparedness, has involved national public health institutes. and where there's been clear collaboration with ministries of health in the relevant parts of the Ministry of Health, whether in clinical services or some of the decentralized approaches through the states and through the districts. And those collaborations have clearly been very effective. In the Nigeria presentation, you focused on the One Health strategy specifically, and this is interesting, where Nigeria also has a national action plan for health security as another multi-year costed strategy, which is actively being implemented and which contains related elements, of course, around health services provision, around provision and continuity of essential health services, such as the ones that we're discussing here today. I'd be very, very curious to learn more from our colleagues from the Nigeria Ministry of Health about the focus on the One Health strategy in lieu of or perhaps complementary to the National Action Plan for Health Security. And fundamentally, when it comes to these sort of conversations around surge preparedness, whether it be workforce, whether it be stockpiles of medical countermeasures, where in Nigeria you see the most important nidus, say centers of governance, and I'm not just focusing on the national level, I'm thinking about at the state level and at further decentralized levels closer to the communities, really trying to shed light on this key issue of how communities and civil society organizations can engage. So could we start again with a perspective on that question from Nigeria around governance, and then we'll turn to our the Zambia context. Thank you.
Okay, thank you, David, for your question. If I get you clearly, okay, thank you. If I get you clearly, is looking at the governance issue, considering the complex structure of the health system and the country itself. But let me correct, I am not Chukwuemeka, I am Daku with the Federal Ministry of Health, whereas Chukwuemeka is a colleague that works closely with us, but he is from Chai.
Oh, sorry, that was my apologies. My apologies. That was the name that was coming up as you were talking. So
understandable, no problem.
Thank you.
So with the coming in of the new government in place, the country adopted what we call the sector-wide approach. And that in itself is trying to look at to solve the complex challenge of health using the One Health approach. So what government has been trying to do using the sector-wide approach is to ensure within the country, we have a One Health report. Within the country, we have one conversation on health. Within the country, we should also be having about having a basket of sources of funding of healthcare. So what that means is that the ministry is trying to coalesce all international partners and donor organizations to come into one, put in their money in a particular basket. And then the subnationals will also have their own work plan, guided by the direction of the national government. And then you can now see where the deficit is, and partners with specific interests on those deficits can now come in to fill those gaps. So you can see that is the first time that approach is being introduced in the country, and is the first time also that we're beginning to see that the subnational, irrespective of whichever government they are, aligning with the central government to achieve that aspect. And the National Action Plan for Health Security, though coordinated by the National Public Health Institute, but still supervised under the Federal Ministry of Health. So in the Federal Ministry of Health, under the swapped agenda of the present government, you have different thematic areas and teams. Like you have the public health security team on one side. You have the primary healthcare team working on a different side. You have the healthcare financing component working on a different site, but all having the same opportunity to look at the whole budget. So yes, for the One Health approach, looking at health from the perspective of the agriculture, Ministry of Agriculture. Now we have Ministry of Agriculture and a Ministry of Animal Husbandry with DEX officers also working with the health, and also the Ministry of Environment also working with the Ministry of Water Resources. So the clear teams coming out from this synergistic work is that one of the major area of a challenge is the human resources for health. The country has been hit with a serious brain drain, where well-trained, highly skilled health professionals tend to migrate to other countries, for greener pastures or for other different reasons. And so you find that the stability of those who will respond to pandemics now and fatigued because of this brain drain. The second aspect is the issue of funding. You discover that most countries suffered from the significant challenge of funding. Nigeria is not exclusive. So you find that the government budget is not enough to meet even areas of priorities. And then for pandemic response and preparedness, that is, but to fund the budget to fund usually not available. So these are some of the challenges that the country is actually facing. So I will want Dr. Okoli to also add to what I've said as regards the Nigerian context. Thank you, and over, please.
Thank you very much. Okay, thank you very much, Dr. Darko. I would like to add that the One Health approach is actually aimed at improving the Nigerian health system generally, because we're looking at the health of the animals, we're looking at the environment, and these are all areas that can affect health in one way or the other. And so the Nigerian government is not just strengthening the Federal Ministry of Health, but we are collaborating with other ministries to ensure that not only the health of humans are in place here, we're talking about the health of animals, and we're talking an enabling environment, an environment that is good for humans to operate in. And apart from that, we're also looking at resilient health systems. Dr. Dakum had mentioned to you about our healthcare workers migrating. And so I know that as we speak now, the Federal Ministry of Health has a healthcare health workforce policy that is aimed at ensuring that we have enough health workforce, and that we also train more health workers, retain the ones that we have in Nigeria at the moment. So thank you very much.
Thank you so much to you and Dr. Dakum for those responses from the Nigeria context. If we could, I'd like to turn to Dr. Mbewa and Prof. Mulenga again on the Zambia context. In a similar question, you very eloquently explained the relationship between the Zambia at MPHI and the Ministry of Health and the programs, in particular HIV and TB, the decentralized, including the community health workforce and community health programs. Could you give us a sense for, in the Zambia context, how future surge preparedness is being thought of? Is it within the existing One Health strategy in Zambia, within the National Action Plan for Health Security, or within other plans? And how is that governance on a regular month-to-month and year-to-year basis? How are you seeing that continue? Thank you.
Thank you, Oh, yes, Prof, please go ahead.
Go ahead, Dr. Nyoma, then Awad.
I was just going to say that so the Institute, the Public Health Institute, is just a wing of the overall Ministry of Health. Our mandate is really health security, and I guess in my department, the emergency preparedness and response, our focus has been in capacity building and some of the IHR responsibilities. So we have developed the new National Action Plan for Health Security, which we hope will be launched in January. And then part of the work towards development of the new NAPS had involved like an alignment process with different sectors, really taking a One Health approach. So we did have an alignment meeting where we had the different major funders. I'm sure you're aware that aside from global funds, as a country, we do have other support such as the pandemic fund. And so we did have a forum where all the different partners and entities were able to identify which aspects of the NAPS they'll be able to support. And then all of this really, whilst the steering committee is anchored at the Institute, it's really under the Ministry of Health and then through the One Health steering platform to the other ministries. But again, deferring to Prof.
Thank you, Dr. Mbewe. As she has indicated, the ZMPHI, which is more of the security wing, is under the Ministry of Health. And anchored under that are various sub-national structures. And we are moving in with a decentralization policy where beyond the district and also the community facilities, we are providing through the community-based volunteers. So it's using this whole integrated system from the community-based volunteers who are feeding into the primary health units, feeding into the first, second, and also third level hospitals. But also one thing which has been done under the ZMPHI is a creation of the field epidemiological, epidemiological officers. So the FETPs, they are able to be the link with the surveillance units under various districts as well, but also cascading those services down. So it's using this channel how we are looking at the preparedness for any future pandemics as well. It's strengthening that. Thank you.
Thank you so much, Prof. Mulenga. Much appreciated. I am not seeing any further questions in the chat. Marcella, please confirm if I've missed anything.
No, you haven't. There's no questions.
Okay, great. Well, wanting to be respectful of everyone's time, I want to ask Sean and Jess from the CHI team whether you'd like to offer any further comments, any specific items from this conversation that you'd like to either react to or reflect further on before we look to close the session. Sean and Jess?
Thanks, Dave. You know, not too many. I think the sort of discussion Q&A part of this call is really focused on, you know, the future surge preparedness governance. You know, I do think it is worth sort of again highlighting like how impressive some of the data is, right? Like you know, and I think a lot of us come to this from the HIV world or other big public health programs, you know, where loss to follow-up and linkage to care is just such a big question and issue that we've always tried to strengthen and improve and sort of work towards, you know, 95, 95, 95. And, you know, if you look at the data for these new programs that were done, you know, maybe not in peak Delta or Omicron waves, but still within the context of an emergency, you know, the ministries of health in Nigeria and in Zambia were really able to initiate people very, very quickly. You know, at the beginning of all of this, there were all these questions of, oh, is this a feasible model? Can you get people to start within 5 days of symptom onset? You know, can you make sure that you go through the protocol and get people started and to take their drugs? And like that, it just really hasn't been a major issue, right? It was just all sort of the data is just very strong on that front. So, we should really applaud our colleagues on that, but then also take away that, working quickly, responding quickly to these types of emergencies is incredibly feasible with the proper tools. And so I just don't want to get lost in that. I know that COVID test and treat is not a priority necessarily for the world at this point, but we do feel like there's a lot to take away from that as we face future emergency after future emergency. And it is exciting to see that this work has led to some of these broader conversations about surge preparedness. How do you actually set up your surveillance system to be able to respond in a smart and effective way, given limited resources in the future? So I just wanted to, hone in on that again, to just make sure we drill that point home, because I think it is really important. Jess, anything that you want to add from the OR, or any other elements that we weren't able to touch in too much detail on?
Yeah, I'll just reiterate what you said. As a researcher, I've conducted a lot of implementation research, and I think with this study, we really showed that data was possible to collect very quickly and within the public sector. So all of our data collection tools, we weren't introduced, they were new tools, but only because they were new tools for the program, right? Like there were no tools, right, that were capturing if oral antivirals were being prescribed and given to patients. So those tools were there. In Zambia, our data entry was even done through REDCap and in a Ministry of Health REDCap server. So, we really tried to be using these systems as much as possible and showing that it's possible not only to be done quickly within the public sector, but still doing an ongoing pandemic. So I think that is very promising for future research as well. Thanks.
Thanks to both.
Reactions to that, but I can go on and I have other reflections, but yeah, any response to that?
No, your both comments very well taken. I mean, it's a really exciting example of real-time operational research in a health emergency, and a particular type of health emergency. But I suspect that in the various papers that you guys have in your publication plan, that will be amongst them, and it will certainly add a lot of insight, going forward. And I hear you. I think we're tending to focus a bit, just in kind of naturally and intuitively on the now and the future, without perhaps taking full stock of the specific success that this was, clinically, and in terms of the community impact. But I think this conversation has given us a lot of reason to be excited about the papers that are coming out, the more detailed discussions that you will be providing on these topics, and we'll look forward to seeing those in due course. And again, Sean, as we've discussed, I think again in bigger picture, these are some of the critical lessons about groups like the Interim Medical Countermeasures Network, and really what matters most. The next time these sort of events come along, this won't be the last time. And Zambia and Nigeria have really been pathfinders and illuminated, again, some critical approaches that others stand to. So very much agree there, and I just want to say thank you again for all the time that's gone into this development and implementation of these projects over the past 2 years, and the close collaborations that you've all demonstrated here between different parts of the health sector, the Ministry of Health, community actors, and with support from technical partners like CHAI. We've really benefited greatly from this, and again, looking forward to all the further fruits that you'll be sharing with us and with the global community in the near future. So, with that, I think we'll go to close the session. Thank you again to everybody for your time and attention.
Can I just also say thank you to the Global Fund, both for hosting this session, but for the work as well. I mean, I think we've we've really enjoyed the collaboration. It's been, you know, immensely helpful. And again, Dave, reiterating, thank you to our Ministry of Health and the PHI colleagues, both from Zambia and from Nigeria today. We really appreciate your time and insight. But Dave, back, I don't want to steal your goodbye thunder. Maybe officially wrap us up, but thank you all again.
We're officially closed. It was a co-closure, so thank you, and thanks everybody for still with us.
Thanks, Dave.
All right, take care, everybody.